I just uploaded a short video on YouTube today, July 27th, 26th. And what it is a lady that's had long-term chronic bacterial cystitis. She has been on antibiotics for a while. She's had considerable improvement in her symptoms, but we seem to be stuck. We can't quite finish the treatment and get her completely asymptomatic for an extended period of time. So we took her to surgery today, and she was asleep, and you can see we look in the urethra with the cystoscope, and you can see in the urethra there's a little hyperemia of the urethra, meaning it's probably a little more inflamed than it should be. But the closer you get to the bladder neck, then you start seeing these hyperplastic polyps. They look like little seaweed flapping in the irrigation of the cystoscope, and that is a hyperplastic polyp is a bladder or urothelial response to chronic inflammation. There are several things that chronic inflammation causes. That's one of the first thing that develops. It's a benign finding. It's not at risk for malignancy, anything like that. Just it's a sign, it's a clue that there's a problem. Further in you get into the bladder there, you can see the trigone. You see another finding that's common in women, squamous metaplasia. That's the white patches. That is normal in many women. I think that squamous metaplasia, however, can be used by the bacteria as a place to hide. These bacteria, when they access the crevices and the hills and the valleys of the squamous metaplasia, it allows them to hide from the antibiotic. It's just a good place for them to hide, and they may be dormant there. They may not be causing really any problem. But the next thing that you see there is the little yellow bubbles. That's cystitis cystica. Cystitis cystica is clear-cut evidence of chronic infection. If you looked at that under the microscope, you would find white blood cells around that. If you went to electron microscopy, you would probably actually see bacteria in there, probably E. coli. That's one of the, you got hyperplasia, you got cystitis cystica, then you have cystitis glandularis, which we did not see in this patient. That's more of a solid tumor-like area of the body's response to chronic inflammation. There is slight risk for malignant degeneration with cystitis glandularis. It's not particularly common. It's always associated with infection or chronic inflammation from something. Could be a bladder stone. Anything that can create chronic inflammation, something that's not supposed to be there. A bladder stone, a ureteral stone that's sitting right at the ureteral orifice, creating chronic inflammation. So other things that we see on the cystoscopy are, you notice the tissue behind the trigone, which is a little redder than it should be. It's erythema. And those are blood vessels that are slightly dilated more than the rest of the bladder, which you notice the bladder mucosa for the most part is normal. So there's nothing dangerous in this cystoscopy. It's just further evidence of chronic inflammation. So the next thing that we did is we destroyed all that chronic inflammatory change. We went with took the resectoscope in there with a loop electrode, and we fulgurated the tissue between the ureteral orifices out towards the bladder neck, and where you see the fibroepithelial polyps. That was all destroyed. The cystitis cystica was destroyed, in hopes that we can take some of the places where these dormant bacteria are living and let the bladder start anew, let the bladder mucosa heal, put down a thin layer of urothelium in hopes that the bladder, the bacteria are not able to attach and become dormant again. She will continue her antibiotics that we have very good evidence have been working, but just lacking penetration. The problem with this condition is you have these dormant bacteria in there, and while we use very good antibiotics that have really good penetration, a problem is you can have all the penetration in the world, but if the bacteria are dormant, not metabolically active, not reproducing, you can't kill them. Many of our antibiotics work by inhibiting cell wall synthesis, inhibiting reproduction, inhibiting protein synthesis. So if the bacteria are dormant, you can't kill them. So what we have to do is get those bacteria into the urine outside of the urothelial cell, where we can have a high concentration of antibiotic in the urine at all times to kill them. And you can imagine if we went in there and stirred up all these bacteria, if the antibiotic that the patient's on is not effective, well, those bacteria just go to the next cell over there and create the same problem again. So hopefully we've done this lady some good, and she will get on to the next step in her treatment. When I have some more information, I'll try to forward it on to y'all about how she's progressing. Thanks.